Hello, hi. So my name is Tariq Munshi. I'm a psychiatrist here in Canada, Ontario. At present, I'm working with the University of Toronto at St. Mike's Hospital, and in the recent past, I've been in Queen's University, Kingston. So many thanks for attending this talk. This is one of my favorite topics. So the issue of metabolic syndrome has come up since the last 15 odd years. We moved from typical antipsychotics to atypical antipsychotics, and it was felt that it solved the problems. However, some years into practice, we came across metabolic syndrome, which plagues the world in general, which I'll go through in a while. And in addition to it, with our medications, it's even bigger problem. So people with severe mental illness are at much greater risk of developing metabolic syndrome. So I first want to declare my conflict of interest. I've spoken for a number of pharmaceutical companies, and as I mentioned, this is my area of interest. So this is a video I have chosen, and it's about leadership. So it's a 3-minute presentation, and
if you've learned a lot about
leadership,
a movement, then let's watch a movement happen, start to finish, in under 3 minutes, and dissect some lessons. First, of course, a leader needs the guts to stand alone and look ridiculous. But what he's doing is so simple, it's almost instructional. This is key. You must be easy to follow. Now here comes the first follower with a crucial role. He publicly shows everyone else how to follow. Notice how the leader embraces him as an equal. So it's not about the leader anymore. It's about them, plural. Notice how he's calling to his friends to join in. So it takes guts to be a first follower. You stand out, you brave ridicule yourself. Being a first follower is an underappreciated form of leadership. The first follower transforms a lone nut into a leader. If the leader is the flint, the first follower is the spark that really makes the fire. Now here's the second follower. This is a turning point. It's proof the first has done well. Now it's not a lone nut and it's not 2 nuts. 3 is a crowd, and a crowd is news. A movement must be public. Make sure outsiders see more than just the leader. Everyone needs to see the followers, because new followers emulate followers, not the leader. Now here come 2 more people, then 3 more immediately. Now we've got momentum. This is the tipping point, and now we have a movement. As more people jump in, it's no longer risky. If they were on the fence before, there's no reason not to join in now. They won't stand out, they won't be ridiculed, and they will be part of the in crowd if they hurry. And over the next minute, you'll see the rest who prefer to stay part of the crowd, because eventually they'd be ridiculed for not joining. And ladies and gentlemen, that is how a movement is made. So let's recap what we've learned. If you are a version of the shirtless dancing guy, all alone, remember the importance of nurturing your first few followers as equals, making everything clearly about the movement, not you. Be public, be easy to follow. But the biggest lesson here, did you catch it? Leadership is overglorified. Yes, it started with the shirtless guy, and he'll get all the credit, but you saw what really happened. It was the first follower that transformed a lone nut into a leader. There's no movement without the first follower. See, we're told that we all need to be leaders, but that would be really ineffective. The best way to make a movement, if you really care, is to courageously follow and show others how to follow. When you find a lone nut doing something great, have the guts to be the first person to stand up and join in.
So the objectives to today's talk is raising awareness of metabolic syndrome and talking about presently available choices in Canada that have a favorable metabolic profile, and it's just an overview of how to manage treating people with severe mental illness. So I'll go through the demographics, risk factors, relation to psych patients, guidelines, limitations. We did an audit with an ACT team and metabolically friendly antipsychotics, overview, and management and current implications and the way forward. So let's start with the definition of metabolic syndrome. It's collectively a group of risk factors which are abdominal obesity, hypertension, hyperglycemia, and a deranged lipid profile. Now, what we know is that according to the International Diabetes Federation, the prevalence is 25 to 34%. Risk is twice as much with people with severe mental illness. The criteria are as follows, which I won't go into a lot of details, but it's pretty basic. And there are different criteria. For South Asians, it's an even bigger problem because the margin for baseline is less than certain other populations. Most of these guidelines initially were made for Caucasians, but for South Asians, it's typically around 36 centimeters of waist. 36 inches of waist and 102 centimeters, and female is lower, 88 centimeters. So the demographics we talked about already. The risk is if you have metabolic syndrome, you're twice as likely to die from 3 times as likely to die from heart attack or stroke. It's considered to be an epidemic. Now, we already know that the life expectancy for people with schizophrenia is much shorter. Studies have shown between 12 to 20 years in different studies. And most of our patients die because of cardiovascular issues. And then second is cancer, again, lifestyle problems, and then about 14% from suicide. So I'll talk about a little small clinical study we did in our acute psychiatric unit, and that showed about 50% met the criteria, and a number of them didn't even have severe mental illness. So this is like more a heterogeneous population of Kingston, where people from different type of diagnosis were admitted to psych units. Now let's talk about etiology. The exact mechanism is unknown. There are different views on this. Obesity plays a part, and insulin resistance might make diabetes worse. There's some references there, and the risk factors have been noted to be stress, of course, increased cortisol levels, aging, of course, and severe mental illness. So people with severe mental illness have sedentary lifestyles, poor dietary habits, limited access to healthcare. Believe it or not, even in the West, they are marginalized and don't receive much adequate physical care. A lot of them don't even have family doctors, and it's left to the psychiatrists to manage their physical health issues as much as we can. So monitoring, and there's different guidelines. The issue is that the consensus is lacking in many services. These are for people who are on antipsychotic drugs. And then there's a bit of hesitancy from services, like for psychiatric services. So the issue is that do we have the expertise to manage their healthcare? They're typically challenging individuals, so family physicians and primary healthcare services can discharge them after some behavioral outbursts. And therefore, the issue of continuity of care comes into play. So these are some of the monitoring guidelines. This is the Canadian guideline, baseline, 12 weeks fasting glucose, blood pressure, waist circumference, blood lipids. So it's pretty standard to see. So I'll move on to our audit, which we did. And we compared with so the purpose of doing an audit is comparing it with a gold standard. So I took a paper from the United Kingdom of assertive outreach team, so a like-for-like study, national audit of 53 teams, 48 teams submitted data for about 2,000 patients, 82%, of course, understandably, were on the psychotic spectrum. The results were not great. Blood pressure was only measured 26%, 36% of the patients. So all of the measurements were done in the 20s. Now, if they were already diagnosed, so they were likely to be tested more. And then subsequently, we did an audit with our ACT teams, and we actually were doing better than them, than the British colleagues. There was some missing data. Actually, blood pressure was measured with most of the patients. We actually did a little bit worse when we redid it. So blood pressure was recorded 100%, weight 60 and 85%. I'm comparing it with 2 years, 2010, 2011, base circumference. So some of the monitoring got better over the course of time. So let's talk about the challenges. So mental illness itself could be a denial of pain or discomfort. Psychotic symptoms may be more disturbing and take precedence. Again, we talked about guidelines, and then also an issue of responsibility and liability between, and patients seem to fall through the cracks between practitioners. And you would probably be surprised to know over there that there's a bit of a demedicalization of psychiatry in the West. I worked in England and I worked in Canada. And it seems that psychiatry is a specialty that's more on the fringes despite the need. So very often we're viewed away from the general hospital. In England, we used to work on standalone psychiatric units. It actually requires a lot of collaboration between primary care physicians and psychiatrists. The collaboration, of course, is better in England. In Canada, private doctors operate more as private practitioners. They're literally much away from the hospital services. And the concept of shared care, we experienced a little bit more through the endeavors of our head of department in Kingston, though. So we used to place psychiatrists in shared care services, including mental health practices, were also part of the service they provided. So let's talk about metabolically friendly antipsychotics. So this is one of the slides, which is one of my favorite ones. I give it to all the trainees. Talks about the therapeutic effects of D2 blockers. Now we've got 2 new products on the market, aripiprazole and brexpiprazole. I'm not sure if they've reached Pakistan yet. I assume they would have at some point. So the issues with D2 blockade, they are effective in managing positive symptoms, but there are some negative symptoms associated with them. Extrapyramidal side effects, sexual dysfunction. And next we go on to 5-HT2 blockade. They are also responsible for the antidepressant and anxiolytic effect, and that's why we've been used to augmenting treatment for depression with low-dose antipsychotics. Then we got 5-HT2C. Again, it talks about improving negative symptoms. And then we got subsequently other actions. around orthostatic hypotension, alpha blockade, and then the histaminergic, which is responsible for weight gain. And then muscarinic, which, as you are aware, we use anti-muscarinic agents to deal with some EPSCs, akathisia. Some of the receptor binding affinities, I won't go too much into detail. We've talked about it already. However, the point to be noted in this slide is if you see here, you should see D2 blockade is lower for clozapine and quetiapine because they are fast dissociators. We can see here the distinct issue with sedation and weight gain, so lower for ziprasidone, which I'll talk about later. Then we move to the metabolic profiles. You can see here clozapine and olanzapine are the worst, followed by risperidone and quetiapine. But you can see here there are a number of products here: aripiprazole, lisinopril, lirasidone, to name a few. Very few EPSCs, if any. Prolactin, you can see none of these agents increase prolactin, which is an interesting fact because metabolically friendly or favorable antipsychotics also do not increase prolactin despite being D2 blockers. So currently there are 5 products on the market: ziprasidone, aripiprazole, lisinopril, and lirasidone. And brexpiprazole is the latest one. Lisinopril became more of an orphan product because it kept on changing hands, but it had a lot of promise. The issue with this is that it's specifically needs to be taken sublingually and causes strange paresthesias. A lot of our patients just swallow it, therefore it's not available. There's no bioavailability. Truly sublingual, as I mentioned, there's a risk of an allergic response to it. I've not seen any. It needs to be kept in mind. And ziprasidone, which was the first drug I encountered over here, metabolically friendly. It's not available in IM over here, but in the States, the issue with it is that patient has to have it with 500 calories twice a day, and most of our patients don't eat twice a day. Move on to aripiprazole, which has been quite a bit of a success here and now has got a depot preparation. It's got a long half-life, and it's been used in different indications: schizophrenia, bipolar, treatment-resistant depression, autism, behavioral issues, and also been used in brain injury. Next one is lirasidone, which is relatively new, but it's been around for a few years now. It's been quite helpful in treating depression, bipolar disorder. The advantage of ziprasidone is just needs to be taken once a day with fewer calories, and a longer half-life, of course, helps. So it's been a useful drug in our arsenal. This is a slide I included just to show you the favorable profile of brexpiprazole here. You can see very low incidence of akathisia and experimental side effects compared to Abilify, where the main complaint has been akathisia, which could be due to the titration. Again, long half-life. Strange enough, you can titrate it pretty fast. Within a week, you can reach the maximum. And so last is management of metabolic syndrome. We talk about caloric restriction, moderate increase in physical activity, change in dietary composition. So the team I worked with would get them gym memberships and also give them advice around diet, which is hard to manage because they have to survive on $1,000 per month through ODSP here. And the other option we had was to go to family doctors and have them prescribe medications for the blood pressure, and if they develop diabetes and statins and whatnot. Those are secondary interventions that have to be put into place if unfortunately someone has developed hypertension or diabetes. Talked about sequencing of interventions. This is consideration of risk. And if your patient is already obese and his family is to diabetes, lifestyle counseling, regular monitoring, referral for structural lifestyle intervention, and switching antipsychotics is also a good option. Prevention would be the first step, helping them with different issues, especially around smoking too. That incredibly increases the risk of cardiovascular problems. Education of mental health clinicians, identifying the needs, baseline assessments. Disseminating information is important, and liaising with family doctors, and communicating if there are concerns about their physical health. Involvement of carers of family from the outset, that all is not lost, and we can help out in many ways. And I talked about consider changing the funding. And establish a temporal relationship, what came first does help. Establish a consensus in the area at least, and establish a therapeutic alliance with your client or patient. It takes a fair bit of time to win their trust, just because of the nature of the illness, their insight, and the attitudes of the services that have caused this breakdown in the relationship. Okay, smoking cessation, talked about adjunctive strategies, initiate change from the outset. And our goal at this point is establishing a metabolic clinic in the city. So I guess there's no discussion because this is a recording. Take-home messages, identifying issue of metabolic syndrome and including it as part of the care plan following the assessment. I hope the objectives have been achieved in this talk. It's an interesting topic, but a very important one. Raising awareness, being aware of the choices, and what we can do about it.